Good morning. This is the Senate Health and Welfare Committee meeting, and it is February 15th. This morning, we have some time to hear from the auditor on a report on price variation in the state health plans. And then we'll also be going back for a look at S-244 and hear from Sarah Teachout of Blue Cross Blue Shield, who was unable to testify the last time we went through the bill. Auditor Hoffer, welcome. It's a pleasure to have you here, and Fran as well. So I assume that you have your testimony planned together. Why don't you just take it over and introduce yourself for the record, and we'd like to hear what you have to say.
Sure. Thank you very much, Madam Chair. Nice to be here. Happy to be patient with the legislature. It happens so infrequently, it's not an issue. First, let me introduce Fran, who joined us about a year and a half ago, and a tremendous find for us. She comes from the Boston area, having worked most recently for the Mass Health Policy Commission. So she has a lot of experience with healthcare and has already produced a number of other really good reports. She's a crackerjack. So a couple of quick remarks before I turn it over to Fran. This issue popped up in my office about 3 or 4 years ago in conversations with my former deputy, Andrew Stein, who I think most of you know. And we had looked at some of the same kind of data Fran found this time around, but we're thinking more in terms of an incentive program for state employees. In the end, I'm really grateful that Fran and Tim both found this group, NASHP, which they were aware of, the National Academy for State Health Policy. They had a webinar on this topic, reference-based pricing. And as a result of that, they were put into contact with the folks from Montana, particularly a woman named Marilyn Bartlett, who I think had a lot to do with developing the program for Montana and helping to implement it. And they've saved a boatload of money in it. So it's a really good example of how to make this work for the state. The data that Fran worked with came from Blue Cross Blue Shield through the Department of Human Resources. And interestingly, you guys, I'm sure you know this, asked the Green Mountain Care Board a couple of years ago to finally get on this question of price transparency and so forth in a broader approach than ours. And their report was issued recently, and their findings mirror ours. So I'm not surprised by that, but I'm glad the timing is good, seemingly. So I think there's a lot at stake here, the opportunity for a lot of savings if people align properly and commit the will and resources. So I'll let Fran tell you about the report, and thank you again for the opportunity.
Well, thank you.
Thanks, Doug. Hi, so I'm Fran Hodgins. As Doug said, I'm relatively new to the office, so nice to speak with all of you today. Madam Chair, how would you—
Fran, before you begin, it might be helpful for us to introduce ourselves so you know, know who's here. So I'm Senator Ginny Lyons. I chair the committee. Ruth, go ahead.
I'm Senator Ruth Hardy. I'm from the Addison district, and I'm the vice chair. Nice to meet you, Fran.
Nice to meet you.
Cheryl.
I'm Cheryl Hooker, Senator from Rutland County. Welcome, Fran.
Ann.
I'm Ann Cummings, and I think by the background you are sitting in my county. I represent Washington County.
And Senator Clerk.
Hi, Fran, nice to meet you. Josh Terenzini, Senator from Rutland County.
And he's the clerk of the committee. That's okay. Thank you, Fran. Go ahead.
Yeah, shall I dive in?
Yes, please.
How would you prefer to handle questions? Do you want to have them just interspersed, or do you want to hold them till the end?
Well, we usually leave it up to the witness. So if you think that your presentation will be explanatory and sort of put off questions, sometimes we ask questions that are coming up in the testimony. Sometimes it's just questions of clarification. So if there are questions of clarification, we'll ask those, and otherwise we'll wait till the end.
Okay, sounds great. Yeah, just shout them out if you've got anything. So let me just share my screen. All right, so as Doug mentioned, I'm going to be speaking with you today about the State Employee Health Plan. And as we dive in, I just want to provide a little bit of background about the state plan. So it's administered by Blue Cross Blue Cross Blue Shield of Vermont, and it covers about 25,000 employees, retirees, and their dependents. And over the 10-year period that we see here, the cost of medical payments has increased about 51%. During that same time period, the number of lives that are covered increased by about 16%. And today I'm going to be speaking with you about price variation. So as you know, or as you may know, price variation occurs when healthcare providers are paid different amounts for the same service. So, for most goods and services, when consumers have good information, they're going to look for the best value. So if they saw goods that were offered at 2 different stores, they're going to seek out the lower price and probably go with that. But we know for a number of reasons that doesn't always happen in healthcare. And when patients use services that are more expensive, it increases the overall cost of delivering care, in this case, the cost for the state. So the example that we have here, we have a state employee in need of an MRI. And if that state employee receives care at hospital A rather than hospital C, the state is going to pay over $2,600 more. The employee probably wouldn't feel that difference because their copay would be the same at either hospital. So we wanted to understand how much price variation there was taking place in the state employee plan. And so as Doug mentioned, we asked Blue Cross for a sample of data from state employees looking at providers and services that were commonly used in 2019. And not surprisingly, we found a big spread in the prices that are paid to providers for state employees' care. So on average, the highest price provider was paid 3.5 times more than the lowest price provider for the services in our sample. But we saw a couple of examples like the ones here where there was an even greater difference between the lowest and highest price provider. And this is not unique to the state employee plan, and the price variation tool that the Green Mountain Care Board put up that Doug just referenced shows the same thing. And this type of data can be helpful for consumers. A patient may use this to select their care, although research has found thus far that patients are not using these types of tools very much. This can be helpful information, though, for policymakers and regulators as we think about what is the appropriate price, what's too high, what's too low, and how we drive providers towards more efficient care. And as Doug mentioned, this topic, most recently our interest was peaked following a NASHP webinar about Montana and how they saved a lot by addressing price variation. So Montana is similar to Vermont in a couple of ways. It's also a rural state, and their employee plan covers roughly the same number of people that our employee plan does. And they were also seeing high variation in prices paid to hospitals, which was making up the bulk of their healthcare costs. And they were in a tough spot. Their health plan reserves were depleted, and their legislature basically said, there's no more money coming, so you need to figure out a way to cut your costs. And so they started to think about various ways that they might do this and landed on reference-based pricing. And reference-based pricing occurs when a healthcare purchaser, so in this instance, it was the state of Montana, assigns an appropriate price, and then they say, that's it, that we're not going to pay any more than that price. And Montana set that price using a multiplier of the Medicare rate. And importantly, they got all acute care hospitals in the state to agree to this reference price. And this matters because it meant that no matter which acute care hospital employees went to, they were going to be receiving the reference price that hospital was. And so it didn't require employees to change their behavior at all, and it didn't limit employees' choice at all in terms of where they could access their care. So given this system, the NASHP organization hired an independent evaluator to see what kind of impact it had. And they found that Montana saved almost $48 million over 3 years after implementing reference-based pricing. So for inpatient services, the average per member per month price decreased by 22% and by 14% for outpatient services. The graph that I have here in the blue, we see the actual and then projected prices for outpatient services under traditional negotiated reimbursement. And then in green, it shows what the reference-based prices were for per member per month costs for outpatient services. A couple of other important findings here. They did not see any hospitals close during this time, and there were no negative impacts reported. And we've basically in our conversations, we heard that this program was celebrated across the spectrum. So, on the one hand, we heard somebody say that their only regret was that this wasn't broader, that it didn't include, public teachers and others as a way to move towards a universal system. But we also saw a conservative legislator touting reference-based pricing as part of their TV ads for a congressional campaign. So pretty widely celebrated in Montana. And given their success, we wanted to see what would that look like in Vermont's health plan. So we used that sample of data from Blue Cross, and we opted to use the midpoint price as our reference price. So I'm just going to walk you through an example here on the right-hand side to demonstrate what I mean by that. So here we have a sample of data in our sample for a CT scan of the abdomen or pelvis. And we got the median prices from 12 hospitals across that are in our network. And hospital D is the midpoint or median price across these hospitals. So we used that as our reference price. And we opted to use the midpoint price for a couple of reasons. First, it's pretty straightforward. And for the purposes of our modeling, it was easy for us to get this. But second, I think more importantly, it represents a reasonable benchmark because we know that at least half of the hospitals are meeting this benchmark or actually doing better than that benchmark. And so from there, we looked at what would the savings be if we set this as the reference price and all of these more expensive providers were actually paid at this reference price instead. One other thing that's worth noting here about this analysis, we did not find that there was one particular hospital that was high across all the services that we looked at. They were sort of all over the map. And so to us, what this signaled is that reference-based pricing probably wouldn't target a specific provider or hospital, but rather it would be looking for areas of inefficiency to see if there are certain procedures that we can bring the costs more in line, or potentially in some instances, if there are procedures that don't make sense to take place at every site. When we looked at cost savings for the 39 services in our sample, we found that using reference-based pricing, we could save approximately $2.3 million annually. But of course, our sample is only a piece of the larger puzzle.
Right.
And we don't know whether our sample is representative of all of the services provided under the state employee plan. But if we achieve that similar level of services, the 13% across for each service, then the total savings could reach over $16 million annually for the plan. And just a couple of other thoughts as I wrap up here. Again, Montana was able to achieve this without limiting the choices that employees have, and there was no action or activity required on the behalf from employers, which is one appealing piece of this model. The second thing is that this is an interesting opportunity for a modestly scaled project. So on the one hand, there's potential for high savings for the state employee plan, but it's not a system-wide change. And so the impact on any particular hospital would be relatively small. So it's kind of two good things there. Potential for big savings for the state, but also modestly scaled impact for hospitals as they would be transitioning to something like this. The third, as Doug mentioned, thinking about how this might interact with other conversations about moving towards value-based payment. And we think that this is something that could actually inform those conversations. So as we move to thinking about something like global-based payments, this could be a step one to figure out, well, what is an efficient price, or where can we eliminate inefficiencies so that we don't bake those into other efforts to move towards value-based payment or global payments. And lastly, as part of our report, we recommended that the Agency of Administration conduct a more comprehensive analysis, just acknowledging that we only looked at a sample of data, and there are a number of ways that you could approach this. So there are some other pieces of this puzzle that would need to be looked into further. But that said, the data is available, and so we don't think this is something that would require many years to move ahead with, but there is some additional analysis needed. So that wraps up the bulk of my presentation, and I'm happy to take any questions.
Okay, thank you very much. Why don't you take your screen down? We also have your presentation on our iPad, so this is it's
Oh, great.
helpful. Yeah, so I do have a couple of questions. It's about regarding Montana. as Montana, when did, I guess, first of all, how long has this been in place in Montana? So the data that they have available.
Yep, they implemented this in state fiscal year 2017.
Okay.
And the independent evaluation looked at the data from 2017, 2018, and 2019. So that is the study period, but it is still in place.
Okay, and as you referenced, obviously this is savings to the state, but it doesn't. There's not. Has Montana looked at the effect of this on their self-insured plans or their quality, their QHPs? Have they looked at any increases in the broader healthcare system? So it's great that there's savings for public employees, and as you said, if it were expanded to municipal or teachers, that would even magnify those savings. But overall, in the overall system, what has been the effect in Montana, if any?
Yeah, I don't think that there have been studies that I know of, and Doug, please feel free to chime in if you've heard differently. But I don't think that that has been studied. You know, the employee plans are going to be a relatively small slice of the total number of patients that are covered. So I don't know what the impact would be there. And I think that was the hope, was that for that person that we spoke with, was that it could lead to broader system change. But I don't know that that has been studied at this time.
Okay. Doug, go ahead.
Yeah, just one quick thought. There's no question that the ongoing effort to address broader global healthcare issues throughout Vermont must continue. And I'm grateful for the board's recent shift. It appears to be a shift. In any case, these are not mutually exclusive. The state could do this on behalf of taxpayers and apparently experience significant savings. And I have to say, I was a little struck by the fact that while you and your colleagues understandably spent a great deal of time dealing with pensions, because it is a great deal of money, I learned from this research that the amount of money the state spends on healthcare coverage for its employees is very similar annually to the pension payment.
It may even be more. It's huge.
So it's, to the extent that this work doesn't interfere with, and to some extent also is helpful to the broader effort, why not? Let's save some money. God knows there's a lot of other things you could do with it.
Yes. Thank you. And that's exactly why we always strive to save money in the public system, but it's difficult when there are negotiated agreements in play. And so sometimes, we'll make suggestions, but then we get pushback from our VSEA folks and others. But this one is certainly worth the effort, as you indicated earlier, the dashboard, transparency dashboard that Green Mountain Care Board has worked on, and we will try to get to look at, is also helpful. But I did have another question, and then I want to open it up for other committee members, because I'm sure there are lots of questions. So 2 questions. And this one is sort of rhetorical, but the effect of these changes on overall hospital sustainability. We've been talking about that financial sustainability, and we're looking at global budgeting in here. We want to move forward on some provisions legislatively that, so that's kind of a question. There will be effects on individual hospitals as this change is put in place, some more than others, depending on where our public employees live. And then the other question I have that Fran, you brought up, was on value-based payments, and what your thinking is on how this might help move value-based payments forward.
Sure. So on the first point, I think all of these healthcare reform efforts, nothing is intended to be hostile towards our hospital systems. But really are looking for better value and better care. And I think we did think about how this would impact hospitals, particularly small hospitals. And one thing I just want to emphasize again is that the kind of scale of this project. So the numbers that we're talking about for any particular procedure, sometimes the hospitals that we looked at in our sample, there was, 3 of these occurring at their hospitals from state employees. And that really varied by the type of procedure. But for example, there might be a smaller hospital that performed 4 colonoscopies. And so the actual actual impact for them of moving towards reference-based pricing, we're talking about in the thousands of dollars. For things that are larger hospitals and more common procedures, it can get up higher per procedure, but we're not talking about in the millions of dollars in terms of the impact here. In terms of thinking about the movement to value-based payment, and Doug, I'm happy to hear your thoughts on this as well. But more what we're thinking here is, as one of the challenges for value-based payments and moving towards global payments is like, what is the right amount to set it at? How do we figure out what is a fair, price or a fair
Reimbursement.
Reimbursement, thank you.
Yeah.
And so,
Or advanced bursement.
yeah. And so we're thinking that this is a way that we can look and say, well, why would it be fair that, for these 10 procedures, this hospital is being paid 10, 20, 30, 50, 100% more than it's the other hospitals in the area that are able to provide a similar service. And so that this could be a way to identify that and remove, in those, specific instances, remove some of the inefficiency and come to a better value.
Okay. Yep. Go ahead.
Just briefly, Montana anticipated your very understandable concern about hospitals generally, and particularly the smaller hospitals in a rural state. And correct me if I'm wrong, Fran, but I think in their program, they held the little hospitals harmless and didn't even include them in this first tranche. They may well be engaged later. It would require some changes to what services they provide and under what circumstances. But as Fran indicated, the impact from those hospitals on state employees is very, very small. So it wouldn't save us a lot of money to engage them, and we can protect them in the short term by just not even including them in the conversation. So to the extent that the agency of administration and or AHS or GMCB want to look at this more closely, that's one way to protect them, is just hold them out for now anyway.
Yeah, in Montana, they did not include critical access hospitals.
Right, which is a significant number in our state.
Oh, yeah.
But so, I mean, we would be looking at just a couple of hospitals, but your comment about having this evaluated further, and I think this is a good time to do that, given where we are with the financial sustainability concerns that we have. So it may be that we can include this in some of our some of our work.
Yeah, and I would just add that Marilyn Bartlett, who we spoke with in Montana, they did a really detailed dive looking at the financials of the hospitals that they were working with to make sure that the prices that they were going to be paid were going to be fair. They didn't want anybody to go out of business. And it's also worth noting, there's sort of within a bracket in terms of how they priced what they set the prices at for various hospitals. And so there was some variability when they felt that there was needed variation in prices across the system.
Okay, yes, thank you. And just to comment on NASHB, I think that I am particularly supportive of NASHB. They're always so helpful. And I was really privileged to give an address to the group in, I guess it was Jacksonville, Florida, a couple of years ago on some of our prescription drug work. So they're very helpful to states. So pleased that you worked with them. Senator Hardy.
Thank you, Madam Chair. Thanks for this report. It's really interesting. I have a few questions. One is sort of about the logistics from the employee side. So if a state employee were going to get a colonoscopy, since that's the example that's been used, what would they see from their side in terms of how they would access their options?
That's a great question. And that's something that we asked the Montana folks as well. Like, what was the impact on employees? And they basically said, I don't think employees even knew that this happened. Like, there's almost no impact from their perspective because they didn't restrict their choices in any way. I think since a lot of this happened behind the scenes, the employees were able to access the same networks of care that they had previously. They weren't directed to go anywhere in particular, and that's because they were able to get all acute care hospitals on board. I guess one long-term impact is that their premium prices weren't raising for state employees, but they might not even have known that. I don't think it was a super, employees probably didn't feel the impact or didn't even know that they were feeling the impact of this type of program.
Okay, so they weren't told these are the 5 hospitals you can choose to go to for a colonoscopy or anything. Okay.
No.
And then Senator Lyons mentioned this, but did it have an impact on any collective bargaining agreements? Did they have to rebargain anything, or was it done within the auspices of those agreements?
So in Montana, they did not have to make any changes or any bargaining agreements. I don't believe that would be the case here, but I think that there would need to be a more formal answer from a different entity. I don't know that I can speak to that in particular, but at least in the Montana case, there was no need to renegotiate or any bargaining agreements.
Okay. And did you see any evidence or has there been any research done about any cost shifting? We see that in healthcare all the time. When we restrict the cost on one thing, the other costs go up. So if state employees are getting a better deal, does it mean the rest of people accessing those colonoscopies are now paying more?
I think that's a fair question for sure. We don't want to step on one end of the balloon and have it go up over here, right? But I think that's where we would see an entity like the Green Mountain Care Board or the payers coming in to make sure that that is not happening unnecessarily. And so that is definitely something to watch for and think about as we move forward. If we were to move forward with something like this, what would be the unintended consequences, and how might what role the state might play or payers might play in ensuring that type of inflating in other areas doesn't take place.
Mm-hmm. And then you mentioned that there would be some additional work needed prior to implementing anything. That seems to be the common theme with kind of everything we're looking at, and which is understandable, but there's only so many hands to do the work, and I'm afraid there are not enough hands to make light work, as the saying goes, or sort of something like that. So what would be the next steps if we were to try to pursue something like this for next, after this legislative session? What would have to happen?
Fran, can I make a comment here?
Please.
Senator Hardy, it's a great question. In our case, as Fran pointed out, we looked at a sampling of procedures. Basically, what would be required is an examination and investigation of all the procedures. That data exists. So no new data would have to be created. The analysis is very straightforward for people who are, decent analysts. And it's not that big a deal. Some of the things that the board is looking at are global. They're hypothetical. There is no example to work from. This is very straightforward. In fact, this could probably be done this year.
So you mentioned that the Green Mountain Care Board came out with similar recommendations or a report recently. Did that have data analysis in it?
They had the same analysis, but broader, much broader. They reviewed all payers. In our work, in Fran's work, it was only the state as a payer in this case.
I see.
So all of the information is already there. And all we're talking about is a conversation amongst you and your colleagues and the administration ultimately about, well, how far do you want to go? Do you want to do what Montana did, exclude the little guys? Is there a way to keep them in? Those are the kind of questions that further analysis will allow you or will inform your debate down the road. And I think that can be done pretty quickly.
Okay, yeah, time is of the essence at this point in the session, as you know, Mr. Auditor. So trying to figure out what's doable and what literally language that would be necessary or whatever if we decide to pursue something like this.
I'd like to hope that the administration would partner with you. We have not spoken with them yet. We certainly provide them with these reports when they're released, but we haven't heard back. We intend to approach them and have the conversation as we are with you.
Great, thank you.
All right, thank you. And the cost shift question was the one that I was asking earlier about the effect on other folks. So That is a big question. And I have two other questions, and I think Senator Hooker, you have a question.
Just
Go ahead.
going to the cost shift. I mean, I've been made aware from one of my constituents about the difference in pricing when she went to find out about an MRI, and it was substantial. I mean, $1,200 to $4,200. So it's already there. I mean, they're suffering. Commercial payers are suffering as well. And I guess my question is there any data that indicates why there's such differentials? I mean, I know that there are reasons for hospitals to charge different prices, but why such differentials?
That's a great question. People have tried to sort of nail this down, and I think there was a study that was actually prepared for the Green Mountain Care Board, I want to say in 2014, but we can pass it along to you as well, that was trying to answer exactly this question. Like, why is this happening? Why is this taking place? And there are sort of some legitimate reasons that some places might be more higher priced than other places, or perhaps, a patient has just is more sick and they need a higher level of care, something like that, has other factors. But a lot of the variation in price is not explained, and we don't know why it's occurring. And so in those cases, that's sometimes labeled unwarranted variation. And that is the type of variation that you would hope to target with something like this, because that is not providing a benefit. We don't really know why it's occurring. There's some talk about whether some health systems have more negotiating power and are able to ask for or receive higher prices than other providers. That might be part of it. I think people that have been working in this field acknowledge that a lot of the pricing around medical services and the charge masters, it's often like a long historic process that builds on itself year over year, and it's not always clear how various procedures are priced out. So it's a great question about why it's occurring. And since we can't seem to explain it all the time, and sometimes it doesn't seem like there's legitimate reasons, that's part of why we would want to target something like that in this type of program.
Can I add something to that? The idea of the cost shift is not fantasy, it's real. But the evidence that Fran found in the data from Blue Cross shows clearly that throughout the system, the so-called cost of procedure A varies enormously. So our question is, why is there so much difference today? Fran's point about pushing the balloon one way or the other, that's all important. But basically, this is getting at the question, why does your hospital need to charge $4,000 for something that her hospital can do for $2,000? As Senator Hooker said, that shift is occurring every single day. And I can't think of a good reason why the state shouldn't use its leverage, its buying power. Everything else the state buys, everything goes to an RFP, not healthcare. We have no control over this whatsoever, zero.
But one of the things that you're raising is that the negotiation between the public, our employees, and Blue Cross and Blue Shield is more transparent. So the state knows what is in that contract, but other contracts are not transparent. So we don't know what's in the contracts between hospital A, B, and C for other patients or services. So it makes it very difficult to get at exactly what you're asking, and that is to get at the price differential. Why are they charging for it?
Right, but the board just produced a report that has all of that information.
Yeah, I know, for the
Every
first time.
single payer, not just the state.
We are aware of that, and it was I think because of a lot of push from our side. Yeah.
Indeed.
So we want to see that information. We want that to be a part of the decision making. So as you were looking at Montana, can you help us understand, or does Montana deal only with specialty care, or is it all hospital care, including primary care, clinics, and pediatrics? Or is this the whole ball of wax, or is it specialty care? That's one question. I have another one.
I would have to double check that, but it's all inpatient and outpatient care. I'm pretty sure of that. So it's pretty widespread.
Okay, well, but it would be helpful to know whether it's restricted in Montana in any way to a specific level of care. That makes a difference. And because right now our VSEA folks have zero copays with primary care, so it wouldn't affect primary care. Then the other question I have is, we have a large hospital on the other side of the Connecticut River. So have you thought through how that relationship would be affected,
Yeah,
if at all?
they're part of our network. So we did include, we didn't have the hospital names, but that would be included as part of this.
Okay.
Proposal.
Thank you. That's good. All right. Committee, other questions? This is terrific. No other questions? And have you thought about how we could entice our NEA and our municipal employees into the discussion?
Well, I can tell you that NEA is very anxious to engage with you on this subject.
Good.
And they have been talking with VSEA. We're not a party to that, but we're told that they've had very promising discussions with VSEA. And if those two entities agreed, it would make your life a lot easier, but it would also perhaps double the potential savings annually from what, if we could reach what Montana did, that would be tremendous, but potentially you could double that. And furthermore, if you wanted to keep going, you could start talking about municipal employees.
Right.
And then you get at the question of, how much of the state are we talking about? That's a pretty big group of people, state and local. So that would, I think, help the board move the needle towards global budgeting for sure. I hope.
Absolutely. Okay. Thank you.
You're welcome. Thank you.
Yeah, no, that's great. Senator Cummings or Senator Terenzini, any questions? No, we're good. All right. This is terrific. We thank you for the report, and we do have the recent report from Green Mountain Care Board, financial sustainability, and on the recent benchmarking plan that I just read this morning or yesterday, I forgot when. Anyway, so there's a lot of data included in all of the reports that we've been getting. It's very helpful.
Great.
Okay.
Well, thank you for the time.
Thank you for your time.
Appreciate
And Fran, it's nice to meet you, and thank you for
Nice
your
to
work.
meet you. Thank
All
you.
right. So committee, what I'm going to suggest is we take a little break until 10:10, 10:15, let's say 10:10. That's sufficient. And then we'll come back, and we have Sarah Teach out here to talk about S244. A little break.
11:10, you mean?
Oh, yes.
Yeah, okay.
Thank you.
Yeah, thank
I'm
you.
even looking at it and saying,
We want you back tonight, Senator.
oh, okay, 11:10.